My name is John Bluford, and I'm the President and CEO of Truman Medical Centers in Kansas City, Missouri. And I also happen to serve this year as the Chairman of the American Hospital Association Board of Trustees. So welcome again, and thank you very much for being here. It is my pleasure to lead this special session to share more details about the national call to action to eliminate healthcare disparities and promote equity of care. Earlier today, our President, Rich Umdenstock of the AHA, announced this collaborative call to action. And in this session, we will have an opportunity to hear from each of the partner organizations about why we came together to promote this effort and focus the hospital field on a matter that is of great concern to all of us.
CHA has long had a concern for diversity and a concern about disparities of care. And we are continuing to engage our members in efforts to understand this issue and what happens with disparities of care and how serious a problem it is, as well as sharing successful means to eliminate it. In April, for instance, in our National Minority Health Month, we decided to celebrate it by launching a web-based project that highlighted various Catholic Health Ministries' efforts to eliminate disparities of care. The important thing about this was not just to celebrate these efforts, but the fact that these efforts are so replicable by other members of our ministry. And now, as we share with all healthcare providers, I think we can greatly accelerate by sharing these efforts that are replicable in whoever sponsors your ministry. So we also have taken advantage of our website to supply the public and our members with other kinds of things that speak to this issue. For instance, an interactive website on ethics, the ethical component of disparities of care. Last summer, we dedicated an entire issue of our ministry magazine, Health Progress, to the topic of diversity and disparities of care, particularly looking at the importance of board and staff composition if we are really going to get at disparities of care. So we look forward to being an active partner with all of those who have pledged to become part of this, and to sharing all the lessons learned with all the members of our ministry, so that we can someday have a press conference in the near future celebrating the elimination of disparities of care. Thank you. Tom?
But a little different take as a professional society, we think our greatest contribution can be increasing diversity in leadership, and that more diverse leaders will quicken our pace in eliminating disparities. So the types of things that we've been involved in and continue to, and we'll look forward to working with our partners on, are first of all bringing diverse individuals into the field. We do that through our educational efforts and the scholarships provide. Second is to advancing the career of diverse individuals, and we do that through our career development efforts. Third, and one of the first things we did 20 years ago was research on the career attainments of diverse individuals in our field, and we could have predicted results, but again, we've worked on that. We've done 4 studies in that area now. We publicize those, and we think those are real catalysts for change in the field. And finally, again, making sure that we educate all healthcare executives about the importance of diversity and cultural competence.
Think about our institutions and our membership. We certainly have 300 large teaching hospitals, health systems out there, all of the MD granting institutions in the nation, and this actually fits very well with what we're trying to do across our mission areas. So if you think about the clinical care that we're delivering, our institutions, even though they're 6% of the hospitals, care for about 40% of the inpatient charity care, 28% of all the inpatient Medicaid care. We've got 100,000 physicians in our practice plans that often care for very diverse populations. On the education side, we of course end up educating and training the vast majority of health professionals through our institutions, and trying to think about how we actually educate them better than we have done in the past in thinking about the health of populations that they care for. I think one of the things that's really struck us as we get better at looking at our quality measurement and looking at how we're doing for individuals and for populations, I think we come to the realization that quality is not quality unless it's quality for everyone. And that's a real challenge. I think that our third component of our missions is research. We already have a lot of our faculty and staff that are engaged in health services research around equity of care, quality of care, and outcomes. They do need better data to figure out where we're falling short. And if you think about how do you really target the health of a population without leaving people behind, people who are less well-resourced, people who speak a different language. I mean, one of our institutions in New York translates over 90 languages in their clinical facilities. So all of these are sort of challenges that we believe need to go hand in hand across these mission areas if you really want to succeed. And I think what you're hearing from people is we're also trying to figure out how to learn from one another. And as we try and do a better job with making quality for all, there are a lot of times when people learn lessons that they wish somebody else had told them about. That when you get here, turn left, don't go right. This will work much better. And trying to figure out how we share that information across providers, across institutions, will strengthen our ability to do that in a much more rapid fashion. And we also, particularly with an interest in education, have something called MedEd Portal, which has peer-reviewed curricular information for educators, trainers, to actually figure out how they do a better job training health professionals. A lot of that is focused around quality and safety, population health improvement, and so we're trying to build up what we have as online resources for training the trainers of the next generation of professionals. We also have a tool that's available on the new website that actually helps institutions assess their own level of cultural competency training for their staff. And so we think that we can probably come at this in a variety of different ways in addition with our clinical partners.
So, as John indicated, back in 2007, the AHA took this mantle up very seriously and formed what we initially called a special advisory group looking at disparities. And we took up to engage the field, and that has yielded us to get to this point today. So we're really pleased that what started off as anytime a special advisory group that sounds like it's going to be working itself out of existence has now developed into an equity and care initiative that has been joined by these leading associations across the country. And one of the things that we did in reaching out was the AHA began to tap into partnerships with organizations and people that we may not have fully been aligned with in the past. And examples would include the current chairperson of the NAACP is a member of the committee. We have Chief Steve Atkins, who is a Native American chief, tribal chief of a tribe in Virginia, and a whole host of wide variety of people that we've been able to tap into. And that's been one of our core strengths. When the group first came together, we had a number of individuals that they may not have actually physically lived in Missouri, but it was a show me mentality. This all sounds real good, but is there really going to be teeth behind this? Is this going to really be serious? And we've been able to demonstrate over time that that has been the case. So some of the early results and focus, Sister Carol mentioned some of the language that wound up in the health reform law. We focused a lot in public policy and tried to put some things in the bills that would help to bring some teeth to this. Another area is that on-site websites that we've developed that demonstrate and highlight examples across the field where a lot of our institutions are really have leading practices, so that we don't have to reinvent the wheel. We can go online and look at some of those successes. And another area relates to governance and Tom-related ACHE work around diversity and management. We developed through the Center for Healthcare Governance and also through the Institute for Diversity a governance education program where we have now put through more than 300 minorities that have gone through the center. When people say, I can't find anyone, we have a data pool where you can go online and basically look across the country to help identify minorities who are capable and competent to serve on healthcare boards. And I'm proud to say that Catholic Health Initiatives has one member on our board that went through that program. So those are some of the areas that we worked on. And I think we made a major shift at AHA. Initially, the focus was on public policy. under the leadership of Rick Pollack. And along the way, as several of my colleagues have pointed out, this is really a quality initiative. And so Neil Jeswell is here. We shifted the focus over to HRT and to the quality side of AHA, and so Malik Joshi is now a major part in terms of helping to make this happen. And we've been able to embed the initiative into the strategic plan of the AHA so that it's a core part of the strategies for improving quality across the entire system and across the entire country. So again, we all know the demographics have been pointed out time and time again that by 2042, this will be a majority minority country. And if we just look at the implications in terms of all of the patients that we take care of and the implications for our workforce, for future workforce as well, then clearly we will not be able to accomplish achieving the IOM 6 aims if we really don't focus on how we can improve the care for all Americans across the entire country. So it's an exciting day, and we're really pleased to be a part of this initiative. Thank you.
Thank you all for being here, and it seems when we come back to celebrate the success of this program, we're going to need a larger room. Thank you.